Great to see everyone. And most importantly, our Indiaspora friends who are here, and it's an organization that I believe a lot in. It's been amazing to be a part of that organization for the past few years and meet lovely people around the world. I'm going to pass it over to Sanjeev to get us started, but thank you all for coming, and let's get going.
Datta is a modest man. Let me start by just spending 30 seconds on him. Datta, thank you for the venue. That's the obvious part. Appreciate you doing this with us and for us. But he's a longtime supporter of Indiaspora, and we exist to be a force for good. I'll talk just a little bit for a couple of minutes about Indiaspora in a second. What I do want to say is that Datta is an exemplar of what we look for in our organization, in our network among our stakeholders. His generosity of spirit, his energy, his passion for the work we do, and just an overall good guy, and excels in what he does as well. So thank you very much. We'll get started very shortly with the topic at hand, but I do want to echo Datta in saying that I really appreciate, we at Indiaspora really appreciate all of you being here. It's not easy to come here in the midst of, in general, Bombay traffic during rush hour, but to add to that, the weather today. So thank you so much in choosing to spend your time with us. There are a couple of people I want to acknowledge right up front before I start talking briefly about Indiaspora, who we are and what we do. I'd like to acknowledge the Canadian Consul General in Mumbai, who's here with us, Jeff David. Jeff, if you can take a bow, please, maybe stand up and thank you for being here with us today. And the Indiaspora team, who really makes things happen. We have with us our India CEO and the Managing Director for our Eastern countries. He's here with us from Delhi, Srikumar Nair. He's in the back. He's part of the senior leadership team at Indiaspora. And accompanying him from Delhi is our Director of Community Relations, who helps with the north zone of India and a little bit of work here in the west of the country, but also helps with Africa and the Middle East, Manjula Manoj. She's standing right at the back. And last but not least, the woman who actually made this event happen, in addition to a lot of things that she does at Indiaspora. She is our director here in Western India, handles the western part of the country, is working on some special initiatives right now that we are doing with the next gen of the diaspora. And she also helps extensively with our work in Singapore, Preeta D'Souza. Preeta lives right here in Mumbai. So now that we are done with those acknowledgements, let me spend just 3 or 4 minutes just talking quickly about Indiaspora at a very, very high level, who we are, what we do. I know many of you are familiar with our work, and we have a lot of supporters among you here, but would just like to familiarize those of you that may not know. At Indiaspora, we are a nonprofit entity, and we were founded 14 years ago. Our mission is to inspire and position the global Indian diaspora to be a force for good, and to build bridges among diaspora leaders across countries and professions with leaders resident in India. Our vision is to be the Davos of the global Indian, with elements of Aspen and TED thrown into it. And I hope that you feel like a miniature version of that by the end of tonight. There are 2 sets of stakeholders at Indiaspora. We have our members, who are our donors. They're a community of 400 people around the world, carefully curated, invitation only, based on their accomplishments, based on their resonance with what we do, which I'll get to very, very briefly in a second. And then what we call prominent friends, about 1,000 people around the world. Our members are typically in the business space, because by definition, business people are the kinds of people that have the financial capability to give to a nonprofit like ours. They're entrepreneurs, venture capitalists, private equity folks, bankers, consultants, Fortune 500 CEOs of Indian origin, and so forth. But the prominent friends are also a very important stakeholder set for Indiaspora. Roughly 1,000 of them around the world. And these people are leading lights in fields outside the business space. So they are diplomats, senior government bureaucrats, politicians, artists, scientists, academics, journalists, etc. So a very eclectic community by design of Indian and Indian diaspora leaders. And there are 5 things we work on. I won't go into the details, but I'll just name them. Come, Vishal, please join us. We have one of our panelists who just made his way. Thanks, delighted to see you. We work on philanthropy and social impact, entrepreneurship and innovation, Indiaspora Next, which is our work with the next generation of the diaspora and connecting them with a rising India, thought leadership, which is our 4th pillar out of 5, and thought leadership in the areas of geopolitics, trade, investment, global macroeconomics, technology, studies about the diaspora, and diaspora philanthropy. And then last but not least, our 5th pillar is Global Connect, which is our work around the world. There are 7 countries in which we are extremely active: the United States, Canada, the UK, UAE, India itself, Singapore, and Australia. We're a team of 20 people in terms of staff, scattered across many of these countries. And there's a second tier of countries that we are slowly beginning to get a little more active in, because there's Indian diaspora in about 190 countries around the world, and there's about 37 million, not to mention 1.43 billion people here in India. So the target segment, if you will, for us is somewhat large. But you know, there are countries like South Africa and Mauritius and Fiji and New Zealand and Suriname and, you know, Ireland and even Germany and France, non-English speaking countries where we are slowly beginning to get active in our work. And there's a lot we do under Global Connect. I can talk about that later, or my colleagues can with you after the panel discussion is done. We hold up one large event every year called our Global Forum, which we just completed in Bangalore. Some of you were there in March of this year, and we held an AI summit to go with it as well. And that's something we'll keep doing year after year in our progression towards becoming what is colloquially called, I guess, the Davos of the global Indian. Yeah, so that's just a little bit about Indiaspora. Now, in terms of the panel, I would love for this to be 2 things. Number 1, a substantive but a free-flowing conversation. Many of you, all of you, are the kinds of people who, in your own right, can be, have been, are speakers and panelists at various events. So we are not here to talk at you, we are here to talk with you. And so I will, after the panel discussion, the formal portion of it is concluded, which also I will try to make very conversational. I will invite some, questions and comments, etc., from the audience. All right. So with that said, let me bring up the panelists one by one. In no particular order, we have Dr. Shriram Nene. Shriram is the founder of Pathfinder Health Sciences. And Shriram, please feel free to come up. More importantly, Shriram is really a Renaissance man. I've had the pleasure of interacting with Shriram on a few occasions, as have others at Indiaspora. And the repertoire, the breadth of sort of the various dimensions that he brings perspectives from in different elements and different realms and then connects the dots makes him quite impressive, really, Shriram. So delighted to have you here. Thanks for being here. I will now move on to Tanya Kukade, senior member of the Pharma, Healthcare and Digital Health Practice at Nishith Desai Associates. Tanya, delighted to have you here. Come join us. I know that we had a call about, was it a week ago, a little less than a week ago, where we had a discussion about the themes that we would talk about today. And I was very interested in hearing your perspectives on that call, and I look forward to you continuing that conversation here this evening. Thanks for being here. By the way, Nishith Desai Associates, I should mention, it's the eponymously named firm after Nishith Desai, who is sitting here to my right in the first row. He's known to many of you, I know, and is a longtime Indiaspora supporter. As is Dr. Milind Antani, who is a senior partner at the firm, who is his and Tanya's colleague as well. And certainly, last but not least, another very, very good friend of Indiaspora and a longtime collaborator, partner in crime. We've done various things with you, Vishal, in Mumbai and outside Mumbai. Vishal Gondal, the founder of GOQii. Come, please join us. Uh, Vishal, by the way, is an entrepreneur and an angel investor and is often referred to in various media publications as the father of gaming in India. But he also has a healthcare angle, which we'll get to, obviously. So let's get started, really. I just want to very, very briefly set the stage before I turn it over to my panelists. We are really here to learn from and hear from them. But the topic of this discussion, of course, is wellness. And wellness is much broader than healthcare, obviously. It's the need of the hour in terms of having conversations about it substantively. It involves innovation, it involves technology, it involves policy, it involves individual initiative. It does involve healthcare as well. It could involve medication, it could involve meditation, it could involve so many different things. It's a broad topic, but it's a topic that is, like I said, the crying need of the hour and something that all of us would do well to practice. So I'm very glad to be having this timely discussion and conversation. Let me start with one question for, I guess, all the panelists before I get down to an individual question. And like I said, let's keep this conversational. I'll start with Shriram and then move to Tanya and then move to Vishal. Shriram, what is wellness looking like for you today? What do you expect it to look like 10 years from now? And how has it changed from what it was perceived as 10 years ago?
Thank you, and thank you for thanks for inviting me here. It's an absolute pleasure to meet with some of my friends, Nishith and Vishal, and now I've met Tanya and you again. And so we're going to have a good time. I think I'll learn as much from you as you'll learn from me along the journey. And so for introduction purposes, I have done a lot of things in my life. And the interesting part about that is I'm always learning. And when you talk about wellness, it's not one thing. It's many different things put together along a continuum.
Is your mic working? I'm not sure it's working. Why don't you?
I think it's working, but they need to turn up the volume. Hello? Can you hear me now? Okay, sorry. Wellness is a continuum from the day you're born till the day you pass. And the interesting part is we talk about longevity measures. We talk about, sorry, we're going to get a lot.
Why don't you just use this?
Okay, that's much better, thank you. So we talk about longevity, we talk about wellness in the context of things. Imagine my life 20, 30 years ago as a heart surgeon. And the idea, I'm just gonna stand up because I think I'm getting reverb from this. Can you guys all hear me now? Okay, great. Can you hear me now? So as a heart surgeon, I came in at the last minute when someone had a ruptured aorta or coronaries plugged or a valve which wasn't working to quote unquote save the day. And 99.9% of the time you could come in and do that. But the thing you couldn't do was turn back the clock. And all of those behaviors that they had put into place early on in their life came back to haunt them. So you could save them for that day, but they would go on to come back to you later. So that was the first thing, that health becomes a small part of your bigger life, but it has to be something which is there. The second theme which became recurrent was that we are more interested in treating acute care as a business model. And rather than acute care, it has to be something which is continuous care. It should not be episodic. And so one of the changes which I think is going to happen is that healthcare is going to become more in your pocket. Some of the things we're working on, agentics, other things where we put a doctor in your pocket 24/7, 365 as a triage engine which changes the way you behave. Then the third thing is various pillars for life, because I say there's three main things, right? There's a lack of awareness. And what I mean by that is when you're born, you're slapped on the butt, you take your first breath, but you're not given a manual for life. And that manual is different for each of us because your genes are different, your lifestyles are different, everything. The second thing is there's no access to evidence-based international standards for everyone. And the idea to democratize healthcare, because it's not a discretionary spend. Whether you're rich or poor, you're still going to be afflicted with the same issues at different time points. And so giving access is one of the keys, and I think Indiaspora is a huge fan of that. Vishal and I obviously have worked in that realm, and Tanya is like moving in that realm as well. And I think everyone in the room, my guess is doing that on a personal or public level. And then the last thing is alignment. The business of medicine is not aligned with the patient. And the idea is that in an acute care model, you make money off a patient when you see them. If we switch to a chronic care, continuous episodic model, a non-episodic model, then all of a sudden you prevent, early recognize, and early treat. So we got to move from late natural history of disease, which is common in India, with a lifespan less than 69 on average, versus 79 or 70, 80 in the US, where people were dying of maternal fetal mortality. That's actually been corrected. And where little things meant a lot. I see India changing dramatically, and from India, I think we can lead the world. So I think if we can attack these and make it more of health care and wellness than sick care, and you've heard all the terms. And then the second major theme we'll talk about is longevity. But look, does anyone want to live to 100 where the last 20 years you're bedbound in a diaper with a feeding tube? I don't think anyone in the room wants to do that. So the other part of wellness is health span. And so we'll talk about all of these topics during this, but these are the things we're interested in.
Thank you. That's great. Please go ahead.
Right, so I think I'll take your third part, and Dr. Nene actually put everything into perspective, and I've learned so much in just 1 hour of talking to him right now today that gives me immense outlook towards wellness in general, because he's doing so much in the field in general. When we've had the chance to work with Mr. Vishal as well in the past, and just the research on what they're doing, what technology they're working on was so eye-opening, because it's very well existent out in the industry, right? But to deal with your question, really, I will go from the third part up. What I thought of wellness 10 years ago, I do not think I had the knowledge or even understanding of what wellness would be or what wellness is, because I think it was way far back when, in my time, and I'm saying this in my time because I was a child back then. But at that time, for me, wellness was just, me going to school, me going home, playing with my friends, and I'm happy, I'm well, I'm healthy. But now when I look at the same age group, that is 10 years back, when I look at the same age group, they're so much more aware. They're tracking, I've seen people tracking their steps, I've seen people tracking their calories at 14, and I'm just surprised each time I meet like a youngster coming from so many different, walks of life. And they're so much more aware. So at present, for me, what would have been something that would have been a natural, that is, tracking or trying to become healthy, living a well lifestyle, is coming to me as a sustenance at this point of my time in life, because I've just about started to adapt to healthy lifestyles, looking at, if I want to have a healthy future, I would want to avoid diseases, I would want to avoid being sick, I would want to avoid my family being sick. But this is something that I'm picking up now, what people would have already started picking up when they're 10, 12 at this time in life. So I think it's very, very interesting how everyone's perspective is very different to wellness and health lifestyle in general. The third thing that you mentioned would be, what do you see wellness to be 10 years from now? I think in general, this is something that is happening. It's very much happening now and will continue to happen in the future. Is we're moving from a very reactive, I would say generic wellness lifestyle models to very predictive, personalized models, where wellness becomes or is becoming a part of the day-to-day lifestyle, which is in fact very important, but it's also important that people are talking about it even more now. So I think that would be my idea of what I'm looking at wellness as.
Thanks, Sanjeev, and again, great to be here. And Dr. Nene is really the true torchbearer of this, and he's been an inspiration. I'm glad to be here, and I think it's amazing that between the Pathfinder and the disruptor, we have the speed breaker, which is the lawyer who kind of always stops us from doing things. But jokes aside, I am actually not a big fan of the word wellness, because wellness was a very casual word. Everything became wellness, right from all the Instagram reels and all the, fake health advice in the name of wellness. What we are graduating towards, or what the world is moving towards, is preventive healthcare. I think that's really what is being adopted in healthcare systems. That is what is being looked at seriously from a budget perspective. And that is really what the future is. And just to kind of give you a glimpse of this, today, when we talk of preventive healthcare, the 4 pillars of preventive healthcare is prediction. I think today with a decent AI model, if you are able to give your blood work, your lifestyle data, etc., and just with some decent parameters, there is a very good level of predictability of what could go wrong, or what is going to go, or what is already wrong with you. The second is personalization. It is no longer going to be about one size fits all. Based on the prediction and your biomarkers, already there are models which are using orchestration layers, because there is a huge problem of hallucination. So I want to caveat that, where we are able to personalize therapy for each person. And then the third thing is prevention. So whatever was predicted, have you been able to prevent it? And the last and the most important thing is, do you have proof? I think today, in the name of wellness, there is so much snake oil being sold in the market, which is not evidence-based, there is no proof of people going into hyperbaric chambers and, rubbing their fingers and whatever else, right? So there is so much of foo-foo science in this. So the whole concept of preventive wellness or preventive health is that whatever we are talking about, you need to now back it with proof and evidence, so that that can be incorporated into a system. So I think that's really where wellness, which started with all our yoga gurus on TV and all the TV channels, and today every second person is a fitness and health influencer. I saw somebody with an Instagram reel saying that he had beer and pizza, and with his CGM, his glycemic index went down. Now and that's what he's saying, that have beer and pizza together. That guy doesn't know that the alcohol is impairing his insulin resistance, and that's why the CGM is not showing. But for a simple person, that, next time I'm going to have pizza, I should have beer with it.
I wish someone had prescribed me that diet.
It's not going to work.
There are so many threads that one can unpack from this conversation, just these opening remarks. Just one quick observation, and then I'll turn it back to the panelists. Sometimes throwing money at the problem is the answer, but sometimes it isn't. And I think all of you will know this better than I do. I know Shriram will definitely know it better than I do, given his past experience in American healthcare. The maternal mortality rate in America lags behind other developed countries, despite the fact that America spends a quantum multiple on healthcare than do other developed countries. So I'm not neglecting the role of finance and capital and money, but it is not always the be-all and end-all. There's a lot around innovation, community, regulation, and a lot of other factors as well. That's just the simple observation that I have. But I want to turn it back to you. And again, I guess I'll start with Shriram, just sort of in the order of how we started the first time, but feel free to comment on what each other is saying as well. The point about technology, I think all three of you have emphasized it. I mean, we can double click on how technology will make wellness different tomorrow than it is today. You've started alluding to that in your remarks already, and I want to turn that question to you, Shriram. And there's a lot of other strands that we should pick up on, data privacy, ethics, there's a lot of factors and dimensions to this whole issue that we talk about. But let's start with technology. Can you give us concrete, practical examples of how technology will make wellness better and more accessible? You brought that up about, privileged and not so privileged. So how will it make it better, more accurate, and more accessible tomorrow than it is today?
So let's break it down, right? As I see it, we talked about awareness, access, and alignment, right? If you talk about awareness, the biggest technological thing is your big thumb on the reels and the Instagram and social media and everything else, which are good and bad. A lot of information, I don't know how many of you guys have been following the AI saga, right? I learned more about AI from YouTube and from various other places than I ever did from any books or anything like that. And the interesting part, as I was traveling around in the US, every student who was graduating was booing AI because they couldn't get jobs. That's a separate deal. But if they were AI empowered, they were a whole different actor, right? So I would say using media and AI, you might be able to raise awareness and thereby improve what people do. The beer and pizza comment he made. If someone had just deflated or done that, and I run a small YouTube channel, it has 500,000 subscribers, and we do myth busting, right? And I did one on AI versus Dr. Nene, and this was several years ago, and the comedy of it is, back then it was hallucinating a lot, so it could not keep up with me. Now it's gotten to the point where they have models which are trained, and they can actually keep up and do a lot of the triage and a lot of the early stuff. So what I see is the AI models for the first gen, which is LLM, then the prediction, and then general, will change how we can distribute it. And the one thing in India which I see is remarkable is we have leapfrogged. We didn't have landlines, we went straight to mobile. And it's not one India, right? It's 28 states, 8 union territories comprised of 1.54 billion patients, of which 30% are in the metro, 70% in the rural areas. Compare that to only 1 million allopathic doctors at any given time, of which only 2% make it out to the rural areas, and that too during their internships because they're forced to go as their commitment, right? So you have a huge gap in patient-to-bed ratio, patient-to-doctor ratio, all of the other stuff. The only way we can supplant that is by creating tools, and India is a remarkable place for many reasons. And I've been there about 15 years. My ancestors are obviously here, grew up in Dadar or whatnot. And what I've found is the culture is so strong here that we have the ability to scale very rapidly. We have some of the smartest people. Education is a priority. We have billions of points of data, and we don't have HIPAA, right? And so collecting that data and using it to predict who will get into trouble where becomes formidable. And so that's one thing with technology. The second thing is...
You mentioned what HIPAA is for some that might not be familiar.
So it's basically, I don't even know what it stands for, the healthcare privacy, but it has a longer form, which I never can remember. Basically, it blocks you from sharing information. And so in my book, I think that, and I worked on something called iSpirit in the pandemic, creating the infrastructure which became Ayushman Bharat. But the idea is simple, that the patient should be owned by the data should be owned by the patient, not by the technology company, not by the hospitals, not by other people. And if that happens and we anonymize it, we might be able to take billions of points of light and train our models to do something very different which hasn't been done elsewhere. And the third point is, Indians aren't like the Westerners. The books they wrote in Western knowledge, which we're kind of looking at, and I've got a few books coming out in the near future, but the idea is when we looked at all of this stuff, the same variables don't necessarily pertain to the Indian subcontinent for various reasons. The genes, the climate, what we eat, how we've grown up, and so we have to treat it different, but what we're learning from that is remarkable. Then there's these other forms of medicine which no one's really tested. And over time, a lot of them have worked. So there is credibility to the fact that while I, as an allopathic doctor, won't have evidence to say this works, perhaps if we can experiment with that, it could be substantial. But back to your technology point, India is a first mover, right? Because we always get the technology last. And everyone has a smartphone, right? Over 90% do, and most of them are produced in India now, if I'm correct, right? And those go out to the farthest reaches with the advent of Geo, right? When I came here, digital lines, there was 150 million internet connections, of which 100 million were hard, 50 million were mobile. Now compare that to now where you have 600, 700 million, and most of them are mobile. And the cost per GB has gone down dramatically. So the ability to do last mile connectivity is superior. What I see happening with tech is that you won't have to build more hospitals. You won't have to have more doctors. Instead, what you'll do is turn your home into your healthcare palace, and you'll start getting information and awareness and other things, and then also have testing and predictive logic, and at least have a triage engine which identifies which patients are at risk when. If I can predict who will get into trouble when, that's a game changer, you guys. Because if I can tell you, and listen, I'm the first to tell you, I enjoyed my cardiac practice very much because my patients were my family, and I treated them the same way I would my own family. Made it easy was deciding what was right and wrong. But you know what would have been a pleasure and what I do now is I'm coming in much earlier to prevent them from ever having a surgery. The best surgery is the one you never had to have, right? So I think technology can do that, and we can take it to the last mile, and we can provide for people in various weight classes who can afford it or not afford it, and the data may actually anonymize and pay for all of this, right? And so it could be an affordable model which is sustainable, and that's the hard part right now, that how do you provide for so many people? Last point I'm gonna make is, in the US, 18% of their GDP goes to healthcare, and they do not have the best system. Their life expectancy actually went down in the pandemic and due to the opioid crisis. Compare that to the northern European states, which have a much better system, or Japan. Now you look at India, we spend 4% of our GDP, of which 2/3 is private, 1/3 is public. And we take care of 3.5 times the population. It's not perfect. Our life expectancy is 10 years less. I see that changing. I do see that changing. But a young population where 2/3 of the population is below 35 and the median age is 28 is an opportunity in my mind. And so being here at this point for every single one in the room is an opportunity to make a change. And in India, if we build it, we can take it to the world. And I would say we're different because we don't need to port something from the US any longer, like they did. I spoke at NASCOM, and in the 90s, we were porting out talent to basically provide for the US situation. Now we're designing things for our own diaspora here. And I'm saying that that same diaspora in the US and other places suffers from the same disease processes, but they're treated by Western physicians who don't understand it.
You talked, Vishal, you talked about personalized healthcare at the start. You talked about personalized healthcare at the start, and Dr. Nene. They occur, or not preventing diseases, but at least preventing surgeries, and how different populations have different gene pools and have sort of proclivities towards different diseases. In fact, Indiaspora had done a couple of events virtually where we talked to a lot of healthcare experts that spoke about narrow arteries leading to the heart that South Asians typically have. I may not be using medically correct terminology, forgive me, but that's the essence of what they said, and also are more prone perhaps to diabetes, in part because of genes, but in part because of diet as well. So I think both of you have made valid points. Tanya, I want to turn it over to you. You can certainly talk about the technology aspect that I'd asked. I know that at Nishith Desai Associates, you are a wide-ranging firm, and you bring to bear different elements of a situation on any particular field. I've read some of your reports, and I saw them earlier today when I was meeting with Nishith Bhai in the afternoon. So you can certainly comment on that, but I also want to bring you in on something that I know you're an expert on, which is the regulation side, data privacy, portability of healthcare data across countries, where the data resides in what country, telemedicine and the challenges that brings. So that's one element of it, of healthcare. But connect that, if you will, to the overall wellness conversation. Do the same problems that apply to healthcare data apply to wellness more broadly speaking?
Sure, thank you. And in fact, I'll take it up from what Mr. Vishal mentioned in the beginning, right? That wellness, according to him, is a very misconstrued term. It's very generic and it actually forms a part of a lot of factors. So even when I'm looking at wellness, it's not an independent, terminology, right? It's looking at all of my elements. It's looking at emotional well-being, social well-being, it's looking at occupational. I mean, there's so much to it. So when we're looking at improving wellness or healthcare, what are we looking at? We're looking at so many metrics. When we're looking at health, and that's something that a lot of these devices and trackers now also do, is they're tracking your vitals, they're saving it at a platform, which also enables these companies and these technologies to, I mean, of course, Mr. Vishal is better, to give us more insight into this, but just as a high level, example, so that I can bring it into more context of regulations, because that's not something that I want to throw at you. That's something that I want to ease into, because it's very relevant and it's important for all of us. And why I say that is that, Dr. Nene mentioned that individuals should be able to own their data. And that's exactly what our new laws that are coming into picture and will be implemented next year onwards, in fact, want to do. They want to make all of us stakeholders of the data we own. So my personal information, and it can be anything: my name, my email address, my health related information, in fact, my medical history, all of this is going to be my data. I own this data. So I have all the rights on this data and the right on how someone else will be able to use this data in the future. So this is something that a lot of, in fact, not a lot of, all companies, all tech innovators, platforms, and I mean even doctors for that matter, everyone who knows that will come in contact with someone else's personal data is becoming savvy of. Why? Because in the future, the individual who you are actually taking the data from has the right to ask you questions, has the right to question you on why have you collected my data, what data are you collecting from me. And I mean, data is a very general term that I'm using, right? Do you think that you, at this point, would ask someone, why are you asking my question? Why are you taking down my email ID? In the future, this is only one or two aspects of it. Imagine serious chronic illnesses that are very, very prevalent in the country. If someone collects information about these illnesses without actually telling you what that information is being used for, and why that's important is because, Dr. Nene was just talking about how AI is being trained around these aspects, and technology is actually progressing towards getting all of these tiny bits and bits of pieces of information, training their own models to be able to predict better. The more information you store in, the more, predictable or the more accurate results will come out of it, right? So it becomes very important to actually be aware of this. Dr. Nene mentioned that we don't have HIPAA, but what we do have now will be the Digital Data Protection Act, and that's something that has become the buzzword for the past 1.5 years now. And every tech company that we know of has had their ears up, because they know that there's so much liability coming out of and so much compliance coming out of the new laws, right? Why is that happening? Because we want to now make every individual responsible and aware of what's happening with their data. And this is, I would say, it's an evil that's not going to go anywhere. Artificial intelligence, the data processing, it's an evil that's not going anywhere. What will happen now is technology is working around this, right? So it's not going to be a reactive approach. The companies and tech is now going to build around these compliance related aspects. So it's privacy by design is something that most tech platforms, most innovators are looking at. So it comes right from the ground up. When they're starting to build their platforms, they look at, oh my God, what are the checklists that I have to take care of? What are the points that I'm going to trigger compliance at? Why do I want to be compliant? Because at the end of the day, the person who is going to be using, say my device, can ask me, why have you collected my data? Who have you shared this data with? And with companies having such such cross-border reliance on their international partners, and I would say like a lot of service providers outside India, there's a lot of focus on how this data is going to be moving around. Obviously, innovators want the data. They want anonymized data. Now, what is anonymized data? Of course, it's not defined under law as of now, giving you that perspective. But what anonymized data would be that it is decrypted to this extent that you can't go back and encrypt it and connect it to an individual. Now, why is that important? I do have, so for example, as a doctor, and this is something that Dr. Antani keeps telling us, right? So when he was practicing, he wouldn't care about consent, right? So at that time, everything was pen and paper. That's still okay. The second that data goes on your phone, the second that data, I'm sure most of y'all would have also shared your medical reports with your doctors on WhatsApp. Very common practice. My mom does it. I do it too. It's a given that, okay, it's safe. I'm just sending it to the doctor. But do you know that at the end of the day, this information is passing through a platform that you are not even aware of the privacy policy of? I'm sure most of us wouldn't have read those privacy policies. But that's the exact reason, right? So why the data law coming in, and with all the innovators becoming more wary of what I will have to tell them, what I will have to tell the stakeholders, what I will have to tell the patients, is because it's unavoidable, I would say. And it's going up from there. We're looking at privacy by design. We've picked up a lot of these compliances from the UK's law. It's a very strict law, the General Data Protection Rules. I will not go into it because I want to keep it very application based for us to understand easily. It's something that they've been implementing for a while, for almost 3 to 4 decades, I would say. And it's only something that we've picked up now. We've picked up a lot of their aspects to understand and make sure that, while innovation is given a chance to develop, the individual's rights are also taken care of. We're letting companies take up data which is not relatable to an individual, so that they at the back end can still train, can still adapt to technology. And it's not like a speed breaker, like you mentioned that I'm the speed breaker here. I'm not trying to stop technology or innovation. I'm in fact trying to make it such that it relates with what rights I have and you all have, while they're all allowed to make our lives easier, right? So they're also working towards the same goal. We're just trying to make it, I think, to the same road. That would be my input.
Can I just add
Yeah,
one
of
thing?
course.
So one thing to add, so HIPAA is Healthcare Information Privacy Act, just so you know. But the thing is that in the US, which we don't have as much penetration yet, is insurers. And you can imagine that if this information leaks, it could prevent someone from getting insurance. Insurance in India is laughable, right? They have so many exclusions for so long, and it's only on an inpatient basis, to the extent that it's almost useless unless you have a major catastrophic issue, right? And even then, it pays you for some things, not for a room and all that. So right now, maybe 10%, maybe 20%. I think you two can tell me more as to the penetration. But what's critical is what she said, that this information should not be owned. And in the US, one of the things where so this is comedy, but in India, we had no EMRs when I first came. And part of that was to protect, because people would pay in alternate forms, and you didn't want to record an encounter because you didn't want to pay tax on it, right? I don't know. But that was one thing, that's what I was told. But the other part of it was that you would carry around this box of goodies with you to every patient visit that you went to, and there was no EMR, right? There was no electronic medical record. In the US, from 12 onward, it took an extra hour and a half of my day because we had to document everything, and it was the most useless system that you could ever imagine. Believe it or not, the VA was the best system for that because they had it in place much sooner in the 90s, and the thing is, the vets were forced to go through it, right? Whereas the normal population wasn't. But in India, we're still evolving. And it's going to be a wild west for a while until it's not. And the only thing is that the hospitals shouldn't own their patient, right? The patient should own their patient, right? So that's what she's saying, that we need to block the privacy such that no one else gets it. You should have biometric keys. You should have the ability to know exactly in a blockchain kind of format or something which tells you where the data is going, Because without that, they're not going to have trust. And if they don't have trust, they're not going to give you data. If they don't have data, you can't train anything, AIs or otherwise, right? So it's kind of a cascade domino thing.
So I think I just want to add one last point that I think the fundamental problem with healthcare in India and the US is the misalignment of interest. I think there is a for-profit healthcare system, which unfortunately in India is PE, all the PE owns all these hospitals. They're not interested in making anybody healthy. I had a meeting with one of the top hospital CEO, and when I told him that we have systems which can do remote care, he said, I'm not interested. You see, there's a Starbucks in my hospital. I want more people to come here, right? So that is the problem. They are not interested. They need, for a hospital, they need people walking in, just like shopping malls, because the hospital systems are now being literally built like a shopping mall. And then they will always want you to do the blood test in their hospital. They will want you to buy medicines in their hospital. And even though all the labs are NABL certified, every hospital will say, I don't agree with this report and you need to do these reports again over here. So there is the biggest problem of conflict of interest. The second problem is insurers are basically saying, I'm just going to deny claims and that's how I'm going to make money. They don't care. They know that the minute you walk into a hospital with an insurance card, while Dr. Nene thinks you as family, they think you as an ATM machine. And the system is just trying to extract as much money as possible, and we have experienced this ourselves. Everybody has in some way, because for them, it's all about getting as much money out, and the insurance company is basically trying to deny the claim. So it is really, nobody trusts anyone. Insurance company, hospitals, doctors, patients. So all four don't trust each other in the system, which is why we have such a rotten system. And from a technology perspective, think about it. In India, you can press a button and 10 minutes get any product, an iPhone. You can buy a new iPhone, but you won't get an ambulance over here. So is it a technology problem? No, I mean, we have tech to do everything. You know, there'll be drones delivering pizza in your mouth soon, right? They'll fly in and do that. But you can't get a doctor, you can't get medicines, and because of all the conflict of interest. And I think what NHS has done, and we work there, is they fix that conflict of interest. The system is aligned to treat you. Of course, they have a different problem of overloading of the systems and so on, but if you are fundamentally able to solve the misalignment of interest, and US again has the same problem, that, you know, so I think that's really what the crux of the problem is. And I think the way it is going to be solved is by people taking charge of their health. I think if you are just waiting for having a heart attack and then going and finding out my blood pressure was high and I never knew about it, or get a stroke and then, you know, act on it, I think people now need to be proactive. You have devices, you have AI models, you need to take charge of your health. If you are thinking that some doctor, hospital, or insurance company is going to do it for you, then that's not going to work.
I'm glad you mentioned the misalignment of incentives, because that was actually going to be my question for you, but you've covered it anyway, so I'm glad you did that, Vishal. I do have one follow-up question for you specifically, and then I'll open it up to a rapid-fire one-sentence round, and then we'll have the audience come in. And Vishal, my question for you is, beyond wearables, what next? The reason I ask you that question is because in your opening comment, you talked about the need for proof, the need for reliable data, the need to measure and verify that what someone is suggesting to you regarding your wellness, regarding your health, is actually borne out by the numbers. Now, I know today wearables can help. My Apple Watch will tell me how long I stood today instead of sitting down. So that's great. What next? What beyond wearables? What is it that they can do tomorrow that they are not doing today?
So I think clearly the new frontier of health is not longevity or lifespan, but health span. Everybody's saying, you know, including all the billionaires in the world, that how can I live longer and how can I live healthier? I don't want to just live longer for the sake of living longer. And everything around the technology of health is now moving in that direction. And as an interesting update, in 2023, there was a big global prize launched by Peter Diamandis, Elon Musk, called the X Prize Health Span Competition. It's $100 million prize, where what they said is that if you can clinically show with evidence that you can reverse 10 to 20 years in people between 50 and 80, and the time frame given is 7 years. So it starts 2023 and ends in 2030. The prize at the end is roughly $100 million. So about 600 teams from over the world applied for this. And this was a team created with companies, academics, institutions, etc. We created our team with the IIT Bombay, with Ashoka University of Biosciences, and we have just collaborated with IISc. And we are now already in the top 40 in this competition. And the solution which we have built, and everybody, so there is Stanford, Harvard, Mayo Clinic, there are NUS from Singapore, there is Japan. So the 40 teams are all building solutions. And the solutions are either they could use a drug combination, or the only thing they can't do is put you in a captive environment for 6 months and they say we have reversed your age or something. You need to be living your normal life and doing the therapy. So in that, the key aspect, what we are trying to do is we are basically taking multi-omics data. I think, just think about it, your blood test has so much information. Now, the minute you combine your blood biomarkers, your CT scans, X-rays with your DNA and your microbiome, and something called cell-free DNA, which also looks at what's happening in your organs. Now, if you combine all of this and inject lifestyle data into this, suddenly you have what we call a live prediction model. Just the way how you can predict markets, you can literally predict what is going to happen to each biomarker. So that's the system we built. It's called Alive OS. And we then connected it to what we call your digital twin. So we have been able to virtually create your biology, and our teams can literally model that. If this person is going to have this food, we can literally put the food and this exercise, what is going to be their blood levels in 6 days, 10 days, 12 days. And our projections, and we just finished our first clinical study in Delhi, Jaipur and Mumbai. We're going to have Bangalore next. And already we have roughly shown 10 years of age reversal in a cohort of users. And this is, when you say age reversal, again, they were very specific. It is cognitive aging, where they want your cognitive age reversal, muscle aging, and immune age. So it is, aging is not just one number, it was further divided. So the exciting part, what I want to tell you was that the science is now getting evidence-based. Everybody is asking, show me the evidence, because you just don't want to pop random supplements and pills and do all these random tests. And there are so many people trying to sell you things in the name of longevity. So I think it's very exciting times. And Ray Kurzweil, if you have heard of Ray Kurzweil, he's the guy who talked about singularity. He's already predicted that in the 2030s, we will already have all the technology to extend beyond 100 easily. And in the 2040s, we are going to reach what he calls the longevity. There's some word again, he comes up with all these interesting words. So I think the interesting part is just another 10, 15 years, if you can all be around, there is a good chance that all of us can extend our lives, and especially all the young people now. I think there is no doubt in my mind that they can all live over 100. That's really where it's going.
So he's dead on. I think the only thing I would correct, so we had a speaker from the US who you all know, and I won't name him, who came in and he takes all kinds of crazy stuff like transfusions from his kid and 80 supplements per day.
Brian Johnson.
Yeah, and I don't know if this is going public or whatnot, but I think he's a snake oil jar salesman. And the bottom line is that there's a lot of reality and a lot of hoax. And the problem is defining the difference between that is the hard part. In my estimation, I think you can slow down aging, but you're not going to completely reverse it. Because once cellular damage has been done, the apoptosis, where the cells basically lyse, is naturally what happens. If you look at a cancer, it doesn't die, right? and then you need 2 mutations to get to that point. But he's absolutely right that if you look at the genetics, the medical history, family history, social history, the microbiome, and we look at all of these, which we're all looking at as a tribe, if you will, there are potential sites in which you can act and predict where someone will get into trouble. The second thing which we talked about, which I wanted to add on, is I look at these roads, right? And this is a humorous example, so forgive me. But they build them for 9 months so they'll have another road to build, the contractors in Mumbai and in India, and they'll have a job in a year. What they don't look at is the big picture that if you have more traffic through the roads, you'll have additional GST and additional income. Now, maybe that goes to the national government and not to the state government, so there's a little conflict of interest. But my point is that if we're early detecting, preventing, and treating, the number of cases won't go down. It'll actually go up. It's just in the natural history of the disease, it'll be much easier and earlier, and your outcomes will be better. So the predictive power of this is absolutely correct. And I said earlier on that if you live to 110, that's great. But if your joints don't work, your bowels don't work, other things don't work, and you are bedbound, that's not great, right? So the ideal is promoting health span. And all of these tests and all of these measures we're putting into place will not reverse it completely. I think we need to start early, and that's why in India I think we have an opportunity. We're a young nation, right? But the point is that if we can slow down your aging, just with simple tools done repetitively, as well as medicines and other things, we have written about them. I've given talks on the channel on this, rapamycin this, that, the other. We've talked about all kinds of stuff. But to be honest with you, you look at David Sinclair's work. Great example. Works in mice, so if you're a mouse in the audience, you should be excited about this. But I don't think for anyone else in the crowd that I would necessarily prescribe it for you yet, right? It is great for as preventing kidney rejection in kidney transplants, right? But some of that data may actually be there. So I think it's still early. The exciting part is what he's alluded to, that we're heading to a place in science and also with AI identifying genes and folding patterns of proteins where we might be able to get in early and change. Dementia is an example. There's now treatments with CAR-T, with other things where we've designed therapy with CRISPR. And this is the Wild West where we have an opportunity with a combination of technology and healthcare and medicine. And the only question in India is, how do we make it affordable? I'll give you an example, GLP-1s. AI GLP-1s, so GLP-1s, for those who don't know, are glucagon-like peptide agonists, right? They're a game changer for metabolic syndrome. And they may, in the US, they're using them for everything because they've been shown to reduce heart disease or major adverse cardiovascular events at 4 years in patients who are mild to moderately obese, not diabetics. In diabetics, they've shown a 40% reduction in kidney failure. They've shown improvements in longevity, decreases in addictive behavior. They're now being shown to reduce cancer, right? And all of these were the Hollywood Bollywood drug, which were reducing weight, making you look great. But the truth was that weight and the inflammation you get from it might actually be the mitigator for all of these things. And so these kinds of changes, where you can study them in large populations and see outcomes, may be the game changer. And so India is a very powerful place for a number of reasons. We have the people, we have the data pool, we have a government which is open to exploring and kind of getting it out there, and we also have a need. We have too many people who are underserved and an ability to actually take this out to the last mile. So it's an exciting time.
On a lighter note, just talking about cognition and snake oil, I just bought these new shoes from Nike, which are supposed to make me smarter. They have these acupressure points, and so if you like what I'm saying, it's the shoes which are working. They're Nike Mind shoes.
Fascinating. And the possibilities that are sort of the future is pregnant with possibility, and what you said is just mind-boggling. If it comes to fruition 5 or 10 years from now, which based on what you're saying, it looks like it will, it'll be a different world.
Longevity, escape velocity. Yeah, sorry, that was the word.
Okay.
Ray Kurzweil talked.
Thank you. one rapid fire question and then we'll open it up. You know, when I started out, I was talking about Indiaspora being a force for good. And so I'll ask you what may sound a little Pollyannish, but I think that at its heart, the reason that we are all talking about this today, the reason that our friends are part of this conversation today, is because we do believe in it. So at the expense of perhaps exposing my naivety, let me ask you anyway. If you had a magic wand and you dreamt up a healthier society, in one sentence, can you tell me what is the biggest shift that is needed to achieve that healthier society that you're dreaming of? I'll start with Tanya.
Wow, the toughest question to me first. But I think I would say what shift I would prefer would definitely be building innovation on trust and not making trust as a subsequent question that you get in your mind. So building innovation on trust, because that's actually going to be the backbone of wellness and all healthcare future that we talk about.
I think the definition of wealth, the way we measure success, is completely warped, right? I think we are measuring success by how much money you have in your bank account or how much value you have. But the reality is that you could be the richest person, but with no health, you are a nobody. So I think we need to somehow figure out how do we redefine what is true wealth.
On that note, I would say my greatest assets are my family and friends. Because no matter what you have, you are born naked, you leave naked, and in between is life. And what you have really doesn't define it. How much can you eat in a day? How much can you sleep in? And how much can you drive? Now, on a more serious note, I think we have the opportunity to change everything. The diaspora is rich in culture. And this culture is so supportive. If you look at all the southern kind of countries in Europe, as well as India, as well as Southeast Asia, we actually care for each other. And we're not one people. And the interesting part is in the pandemic, I participated with the government, the chief minister, the prime minister in doling out care. It was not easy. But we all came together, and I'm very proud of what we did. We didn't have the infighting or the contentiousness. I see the same thing happening now using a combination of technology, a combination of culture, and a combination of support from each and every individual to build health, happiness, and prosperity. And remember, if you don't have your health, the happiness and prosperity aren't worth much. So I think that would be kind of the keynote for me.
The only thing I would add, my one sentence, is to wish for a healthier society, I would like to see intentional collaboration across different realms, because I think as we've discussed today, there are so many dimensions to making a healthier society, creating a healthier society, that there are different aspects and different professions that need to come together and talk to each other to make that happen. Let me open it up to my friends here. I see one hand. By the way, please raise your hand and please identify yourself, name and affiliation, and if you prefer, what city you are coming from. I know many of you are from Mumbai, but I know some aren't as well. So I see the first hand that I saw here was Suril.
Hi, Shriram Desai from Nishith Desai Associates. I mean, we are talking about wellness, and in wellness, it's all about mental health, right? And in India, we have ostracized it so much and a lot of your well-being is dependent on the politics of your nation or your region. And right now, when a crime happens, it's always blamed on a child who has been brought up badly. No one blames the government for his bad upbringing. So how do we hold governments accountable for our mental health? Because 90% of all our mental health issues are stemming from the decisions that are made in the political corridors of the world. And just like we have right to information, just like we have right to education, because all these AI models are built on our data, we should have right to intelligence. And AI should be a public utility and not a privilege. Thank you.
Who wants to take that? Anyone wants to take that, or is that just a comment that you've absorbed? Okay, all right. I see Akhil here, so I'll get to him and then I'll get to the right side of the room progressively as well. If there's anyone in the back, I'll come to you shortly. Please go ahead.
I think taking an order. Akhil Shahani from the Shahani Group for Institutional Say, Vishal. The thing is that it's interesting guys are talking about AI and law and stuff like that. But it's interesting, I believe that they did some research on the blue zones in the world. And the blue zones, for some of you guys, is basically people who've lived beyond 100 years old and in wellness. And what they said is that it's not really diet or exercise or things like that. It was the presence of community and maybe a life of purpose, right? The thing is that it's really more the mental aspect that you're part of a loving family. Is this actually validated in science, or is this just something that's just hype?
Dr. Nene?
So great point. Let me preface it by saying that Dan Buettner's book, The Blue Zones, was remarkable because it identified 5 countries in the planet, and they found that they had an abnormally high centenarian rate, right? Meaning people living to 100 or more. And the interesting part is they found Power 9 rules from that. These were observations. One of them was socialization and community. Let's move one step beyond that and look the opposite direction. There was a very good study coming from Harvard which looked at loneliness. And it was the equivalent of smoking 15 cigarettes and reduce your lifespan by 15 years. I said what I said in that the Indian culture is very dense and we support each other. If you see how things work, everyone in a building, they might have some infighting once in a while in Jagada, but most of the time they're celebrating one festival after another. And so I see this as something which is very, very important. And while he didn't name India as a blue zone, partly because we have other endemic issues going on at any given time, diabetes, this, that, the other, and plentiful sugary sweets and whatnot, I do think that the culture and socialization is an important thing which protects against loneliness. It also speaks to Cyril's point that I think mental health, sadly, has not been represented. It's a taboo. And honestly, until we own it as something, and this is one thing we didn't talk about, which we should, I came from a place that created DSM-3R, WashU in St. Louis. That's where I trained, and I was obviously not in that realm in psychiatry, but the point is they had no way to treat people for schizophrenia, and then this remarkable drug called haloperidol. The DSM-3R was the Diagnostic and Statistical Manual, which basically gave you a set of behaviors by which you could grade and diagnose someone with mental illness. Why is this important? We're on the brink of deciding and designing both drugs as well as neural pathways, which will kind of actuate what happens. Dopamine, serotonin, this, that. We talk about dopaminergic hits for addictive behavior, right? We also talk about, again, GLP-1s, which actually block some of this stuff. And so the interesting part is, if we own it and identify it as a medical problem, and then use the cultural side of it to basically accept it and say, look, this person's not got something wrong with them, they're sick. Yeah. They need treatment. We will be able to avoid issues. And look, God forbid we become like another country which has very, very liberal gun laws. Fortunately, we don't have that, right? But the bottom line is you don't see that kind of mass murder happening in India, right? But with the type of numbers, we have a statistical curve, right? 1.54 billion, there's a lot of geniuses, but there's a lot of mental illness which is not being addressed. I mean, just the fact that every Indian parent is pushing their kids to do crazy amounts of work for their IIT, and all of the other stuff, to me, is not the right move, particularly right now with AI coming on board, knocking out 40% of the jobs in 10 years, is the prediction. So I think our creativity has to be important. So I'm saying mental illness needs to be addressed, cultural wellness needs to be addressed, and there's clear-cut science which shows, observational, right? And we don't know mechanistically what's going on, but we have an idea. I think as these neurotransmitters are identified, we'll have a better idea of what's going on and maybe have some pill like some of the films where you have no limits, right? Where you can actually get people to perform better. And rather than just a success coach, which all of the great athletes and all of the great CEOs have, maybe everyone will be able to find their kernel of genius, which may not be the same. We've got a varied crowd. How many of you are from tech in this audience? Raise your hand. How many from the arts? And how many from law? And how many from healthcare? So I'm saying, look at the varied audience, and this is what you spoke to, that if we can bring all of these minds together to cross-pollinate and create something, this becomes remarkable, and India is famous for that. So I see an opportunity there.
One of the former surgeons general in America is a person of Indian origin. You might have heard of him, Dr. Vivek Murthy. And Vivek has spoken about two things that Shriram just spoke about right now. He has spoken about, he's a two-time surgeon general, by the way. He has spoken about gun laws in America becoming a problem in terms of overall lifespan and longevity for the overall population at large. And he got into some hot water with the US Senate about that. But he has also, and you will know this, has written extensively about loneliness as a problem. I know there was a question from Dr. Antani. I'll then move to this side of the room, and then I'll come towards the back for the last question.
Yeah, Milind Antani, ENT surgeon in Gujarat and lawyer in Mumbai. With the concept of wellness, what we discussed, the surgeon in me is very excited and the lawyer in me is really worried. And the reason is the connecting link is ethics. Unfortunately, we could not discuss it. That is where the real challenge happens. And when we are talking about reimagining wellness, so if you have to start wellness from the beginning, from the scratch, what we would stop and what we would start, so that at the end of their lives, whether it is living long or feeling greatly connected or purposeful, or maybe happy.
Any responses to that? Anyone want, did you say you raise your hand? No, okay, all right. Okay, all right. I know that this facility does have to close in a short while, so we'll do last two questions and I'll take them together. Oh, please. We actually talked about that. Please, absolutely. Please go ahead. No, that's fine.
So what Milind and I were talking about was, what's your success metric, you guys? What makes you feel good? Don't tell me what your parents are. My parents, I wanted to be an engineer. I wanted to be a business guy and technologist. And I'd gotten into Stanford. My dad's like, look, you got into WashU, and WashU is a combined undergrad med program, and they're giving us more money. And the bottom line, you're either doctor, engineer, or failure, right? So the thing is, what is your success metric, and how do you define it? Because that will define your happiness quotient and your ultimate endpoint, right? And I think as a society, we need to relearn that equation. My sister said it to me. She's like, is it okay to just be okay, right? Do you have to be a billionaire? Do you have to have fancy cars? Do you have to have a house? Some of you may know I would, like Vishal, love cars, and he wears red because he loves Ferraris. He has like a picture on his wall. It's the most amazing thing. But the thing is that as a kid, I would see all these guys, never thought I would once do it. I was an immigrant child. My parents had nothing when they came to the US. And, I love the technology of it. Greater than 100 horsepower from 1 liter of displacement, and how you could do that, right? So my engineering brain was always thinking about that. That's not what defines us, right? It doesn't define me or you or anyone else by what you wear, what you drive, what you live in, apart from that. And if we kind of learn that and teach that early in our kids, so that we appreciate each other's gifts, life becomes better. And I think the success metric has to change for mental health issues as well.
Yeah, I just want to add one quick comment. I think we are all underestimating how fast this technology is going to grow. We think it's incremental. It's not incremental innovation. AI is going to leapfrog. So I think that, very soon, with GLP-1 and all of this, if we are able to take care of non-communicable diseases, which I'm very confident, by the way, we will. I think the entire health paradigm will change because the entire disease burden today, 80% or 70% is because of non-communicable diseases. And I think, I am very confident in the next 5 years, NCDs are gone to the large extent. You have to be an absolute idiot to still be diabetic because, you will have, I was told, and again, don't hold this to me, that in Pakistan, 400 rupees, you are getting GLP-1. So I don't know what they are selling in Pakistan, but yeah. So that is where it is. I mean, at 400 rupees, if GLP-1 is there, it will give mass access to people because all the people with all the chronic issues will be able to take care of it, and that automatically changes the game.
Thank you. I'll take 2 questions at once, and then we'll have to close it down because the facility has to close. We can continue this discussion with them after the formal panel proceedings are done. So I invite all of you to engage with that. But we are privileged to have members of the Godrej family with us. So I'll go to Nadir, I'll get your question. And then there is a gentleman in the back who has patiently been waiting for a long time. So I'll go to him, and then I know there are several hands up. Sweta, I saw yours as well, but we'll get to that in the informal part of the proceedings.
Thank you. I'm Nadir Godrej. We discussed the disincentives of the medical system, and HMOs were set up to take care of that issue. They were supposed to promote wellness, but it doesn't seem to have worked out. Were there any particular reasons for that? Is there some way we can redefine that system to make it promote wellness?
Great question, thank you. And I'll take the other one at the same time here at the back. Please identify yourself as well.
I'm Alfred Aramban, co-founder of Predictive Healthcare Solution based in Mumbai. What has come out very clearly in all your conversation is that India has to take advantage, cultural heritage, diaspora. But at the same time, the lawyers are coming and telling us about GDPR and DPDP. And we are now talking about sovereign protection, including AIs. We've just heard about what US government did with Anthropy. Wouldn't it be smart for us that we kind of enact a raw combination of GDPR and DPDP rather than do cut, copy, paste, where we freely share data. Forget about owning data, share data, and keep the knowledge to ourselves, improve on it, and then share with the world. So it starts with selfishness. Our culture says everything that you do, including dhan pun, you do, because somewhere down it satisfies you. So in a limited sense, why don't we take that advantage? And something that none of you touched is the fact that we have a young population, which is going to get old very soon. And I didn't hear anywhere anybody talk about elderly care. So would you like to throw some light about it? I have spent 7 years of my life committed to making which now everybody talks about, predictive analysis to be affordable, accessible, and accurate. We've sworn by that. But your DPDP thing is going to kill us.
Please, Vishal.
So I think, talking about regulation, so I was part of the Government of India Health Ministry came up with the AI policy. But the biggest problem right now they are facing in India is health is a state subject. So the whole challenge is that there cannot be a central data policy because every state has its own interpretation while they have come up with guidelines around it. And the guidelines are very, very good. Actually, if you read it, the document, it's called SAHI or SAHI. It's called SAHI, whatever is the abbreviation. Google it and you will find that thing. And it is good. The regulation is very, very well made because they took the best of all and we all contributed to it. The simple thing is that as long as there is no personally identified information, you can use the data. That's the golden rule. Of course, there are a lot of nuances to it and everybody is more or less agreed with it. But like I said, the challenge is implementation because it is not a center subject. So I think unlike banking, what happened is banking was easy because it was controlled by RBI. So at center, they could create UPI and implement it and the entire country uses a central banking system, but the central health, there's not a central healthcare system in the country, which is the fundamental challenge. And I think all your answers are stemming around it. On the senior care, actually, there's a lot of initiatives happening. So I'm part of the CII and Niti Aayog Council, where they are working on senior care. There are many startups coming up because we have just started seeing this generation. In fact, there are now dedicated housing complexes being set for seniors. So I think the next 20 years, you're going to see a lot of things, because the current 40s and 50s are all going to enter their 60s and 70s, and they will all have the challenges. So I think and I think the government is definitely thinking about senior care. And about the young, all I can say is that the Gen Z, I fail to understand.
So just to add on to the law aspect of it, of course, the government didn't pick up or put together the data protection law to act against you. It's actually an enabler. So maybe look at law as an enabler to go ahead and make innovation such that people can trust and adopt it, rather than be scared of how it's actually happening at the back end, because nobody's going to look at your code, nobody's going to look at what's actually happening on the platform. What people are going to look at is what they're getting out of that platform. So they should be able to trust it. So I think that would be my little bit on how, and we're there to help you figure out how to actually implement. So, I mean, you have community help you around it, but I think that's a little bit on the data aspect of it.
So, one last thing on that. In the pandemic, we created Arogya Setu, the app, and also the building blocks of Health Stack, which then became Ayushman Bharat. I think it's a changing kind of thing, because that was centralized. And all of the states were working together because they had no options on how to distribute the vaccines fairly, make sure that everyone took their vaccines on time, and also track the disease load so that you could get appropriate services there. Do we need a calamity like that to bring us together? No. But the point is that perhaps this is a conversation which should be opened up. On the senior care, there are a number of people doing it. Sanjay Arora, ex-Suburban, is doing a very nice program with some of this stuff. I've got numerous friends who are building old care homes, and a lot of the Indian diaspora abroad have aging parents here who can't be taken care of well enough. And so they're creating all these communities. And so this is a huge opportunity, because, as I said, 2/3 of the population is below 35, right? And the average age is 28. And your life expectancy is 69, but it's bound to go up with the advent of some of these measures we're taking. So I think that's something which will happen. It's just a matter of time. The other thing is, and this is a great one, that the amount of wealth that's being created in India, believe it or not, has grown. The middle class is burgeoning. And so I see that more people will have the opportunity to actually invest in that for their parents, and they'll also be saving more. It's not just an LIC policy anymore. They're investing in stocks, they're doing other things, right? With respect to Nadir's question, it's a great one. I grew up in that system, and that was one of the things HMOs did. Kaiser was a very famous one. They were very good. HMO stands for Health Maintenance Organization. And the idea is that they have a certain set of protocols, they put everyone through, and they build it rigidly so that you do it. It's almost like the NHS in some regard. And I also I was born in London, grew up in the US, so I suffered through both systems, if you will, and benefited from both. Now, the interesting part is that they do great with standard stuff. But when you have kind of things which happen acutely or otherwise, they're not always incentivized on a physician level or on a caretaker level to really do that. Everyone punches a time clock, is what we found. And I was in private practice as well as in the university systems teaching, and also rotating to some of these hospitals, whether it was Kaiser or the VA or County or UCLA or WashU or the University of Florida, or in private practice in Denver. And I can tell you, each system had interesting things. Now, compared to India, when I came here, I've seen what happens in the government hospitals, at KEM, at various hospitals, Seven Hills, and all that. And I worked with them in the pandemic and other times. I think there's a potential to do it, but I think the main staple, which we've all talked about, is people have to take responsibility for their own lives. it should not be a blame game and wait until the natural history disease forces you into the hospital. What I see happening is moving the ball back rather than the natural history disease to prevention, early recognition, early treatment. And if we do that, then the HMO's role is that you treat it at an earlier stage, which they are very adept at doing. It's the problem that you have a massive cardiac arrest, you come in coding, someone's pumping on your chest, me or one of my colleagues, cutting you open, putting coronaries on, and saving your life. That's very late in the game. And the likelihood of you making out of there, and look, I used to tell patients, families, that there's fates worse than death. That if you survive a massive heart attack or a stroke or something like that, you can be left incapacitated. And I don't think that's anything that you and I would ever want for our family members, for us, or for anyone else. So it bodes on us to build systems like this now. And in a young population, educate early and often. We have a saying that from the cradle to the grave, we're going to be there with you. And even beyond, maybe, who knows. But the bottom line is that if we can intervene and help people to help each other and help themselves, then that's the game changer. And that's where an HMO, I think, would be most effective. For people who have the natural history disease, and there's a lot of things in India which I saw which were only described in books, right? The only other population in the US I saw them in was immigrants coming from Mexico and from places like that who didn't have great medical systems, and you would see them very late in the disease. Like TB, we never saw, and here it's a freaking epidemic. And we're still not addressing it fully. And to Vishal's point, communicable diseases, NCDs, will be wiped out, and then you just have chronic disease, and many of these, with the advent of some of the meds we're using and some of the means we're using, might go down substantially. We thought by 2023 most things would be non-communicable, and then the pandemic came along and changed everything. So things are shifting, and for the better, I hope. And I think we're in the early stages. I think everyone in this room would agree that the potential with these devices and with added kind of data points to see yourself differently is very exciting for all of us. But how do you use that data? What does it tell you? And how do you intervene at a point? Because there's a lot of data, trust me. And we don't know. And we're learning. We're learning. But I think AI is going to help us with that. And I think everything we've talked about is a game changer.
Yeah, I just want to add one last comment. The problem with HMOs, and when we started working with them, is the problem was that these people still looked at the human from organ. There is cardio and kidney and brain and heart, while the integrated health is really the key. And what we are now seeing is a new generation of healthcare systems with integrated health being the core of it. And that's what Ayurveda and everything else looked at, right? You have to look at the full person together and look at longevity and health span. But what problem was that while they were HMOs, they were still fundamentally hospitals. They were just run like hospitals itself. And Narayan Hridralaya in Bangalore is also trying that same model where they want to be an HMO, but finally their biggest business is doing heart surgery. So I think there is a fundamental shift of integrated care. And I think Bhupa, for example, is doing a lot of work. And now there are some new systems. And I think I'm very confident that a lot of HMOs will transition to this.
Episodic care, which is acute care, to a continuous model where you're actually doing that. Raise your hand here. When do you go see the doctor in the room? When you get sick, right? The idea is that's the last time you want to see him. If you can prevent that illness, it's better for you, right? And so to his point, he's absolutely right that they're dealing with the illness, not necessarily the cure. And my dad's an excellent example. We put him on protocol when he was 81, reversed all of his diabetes, took him off meds. He goes back to the US, and we looked at it from a holistic 360-degree angle to try to assess all of his endpoints, right? Diet, exercise, sleep, water, mindfulness, stress, and connection. And, got all the specialists on board. He's now 88, off meds. He had had diabetes for 55 years with a hemoglobin A1C of 7.3, brought it down to 6.1. The only thing his endocrinologist says at his HMO, oh, you lost a little weight. That's great.
I think Milind has one last sentence. Yeah, one last quick sentence. We do need to close.
So quickly, just on that, DPDP is not a cut, copy, paste of GDPR. Let me tell you, that is number one. Unfortunately, DPDP has included healthcare data as a general personal information. There was an act called Disha coming, Digital Information and Security Health. I was a signatory to the bill. Unfortunately, it went into back burner. But for last 4 months, significant movement is going on. I'm a part of the committee where DPDP is going to be implemented May 2027. We have 10.5 months so far. So you are very actively working on bringing criticality of the health data to DPDP, create either an annexure to DPDP where the problems, especially portability and transfer, because unless you have data of the patients, you will not get better treatment. So that type of carve out is likely to happen by May. I'm actively involved in that committee. So that is one thing. And second thing on senior care, government is very active on that. India is going to see hospice care officially very soon, in 6 to 7 months' time. Again, I'm a part of that committee. Home care as well as senior care guidelines are being drafted. And SAHI, which is strategy of AI implementation in healthcare, is also getting implemented. I'm a part of Pillar 5 expert committee, and that should happen next 3-4 months. So, sun is bright.
Thank you. This has been fascinating for a layperson like me. I've learned so much just in the past hour. So thank you all for being here and enlightening us. Please join me in giving them a big hand. Vishal, Tanya, and Shriram. And give yourselves a big hand for coming here on this rainy evening. Thank you all. Enjoy the networking.